This program is brought to you by Emory University.
Good morning, everyone. We're going to go ahead and get started. Welcome to Cardiovascular Grand Rounds. If there are any technical issues, I'm sorry. Our IT guy's on vacation and our student is on spring break, and I started this, so if there's something with the picture or something, we'll just have to look at it on iTunes later. But hopefully this is going out, and if not, I guess you can't hear me, so it doesn't matter. But would like to welcome everyone to Cardiovascular Grand Rounds. This morning we have Dr. Gina Lundberg, who is going to speak with us. Gina is the clinical director of our Women's Heart Center and has had a long-standing interest, obviously, in women's cardiovascular health, and has really been a motive force in driving that effort here at Emory and in the larger scale in the region and the country. And Gina is going to talk to us today about stroke in women. And welcome, Gina. It's good to have you here.
Thank you, Bob.
All right. So you still need that.
I'm afraid. Now, is this going to work for the page up and page down?
So try that. Or maybe an arrow.
Perfect. Oh, well, thank you all for coming out this morning. Dr. Taylor said that if I get a half-filled room, I've done really well, so I appreciate that. And there's a lot of friendly faces in the audience, so thank you. This is my official first Grand Rounds as Emory faculty, so you all be nice to me today, okay? I am a clinician, strictly a clinician. I've been with St. Joseph's Hospital since 1994 and became part of the Emory family when I like to say you all adopted us. I've been doing women and heart disease in Atlanta since about 1998 and have been very involved with reducing risk in women. But when the guidelines for stroke prevention came out in February of 2014, I got really very excited because we had something new to add to our arsenal. So I'm going to spend the next 30, 40 minutes going through these guidelines for you. It's going to be very clinically based and pretty much just a review of the guidelines. I'm very surprised to find how few cardiologists know there are these stroke prevention guidelines for women. And so I want to make sure that you all know the content of the guidelines. As an Emory faculty, I have no disclosures. I have nothing that makes me any money. I would like to disclose to you, though, that I am very passionate about preventing stroke in women. This is the Cardiology Today magazine. I did some interviews for the American Heart Association about this, and then they picked it up. And so I've sort of been labeled the stroke prevention cardiologist ever since. So the objectives are, we're going to go through the guidelines. I'm going to tell you what's in the guidelines. We're going to discuss why women have unique risk, and then appropriate measures to try to prevent stroke in women. And a lot of this applies to men as well. So it's really just a nice review of stroke. So unfortunately, there are 6.8 million people in the United States living after a stroke. 3.8 million of those are women, and about 3 million are men. Stroke is the 5th leading cause of death in men, but it's the 3rd leading cause of death in women. So there's a disparity there. And nearly 60% of stroke deaths in 2010 occurred in women, with over 77,000 of the deaths from stroke in the United States being in women. Okay, so looking at our graphs, this is death rates in numbers of 100,000. And as I was saying, the red is heart disease deaths, and it's been coming down nicely. And you can see a big drop here, and this was about 2003, 2004, when the guidelines for prevention of heart disease in women went into effect. The more turquoise line has been lower all along, but has really been fairly flat from about 1990 to 2012, with very little change. Okay, and that's when you said, if it donks at me. This is the data from 2012 that the CDC published, and these are the total deaths from cardiovascular disease, and yes, they've been coming down nicely from 2000 to 2011. This is coronary heart disease with the biggest change in slope. This is strokes, fairly flat, and then other cardiovascular diseases very flat. So we have a great opportunity here to try to improve deaths from stroke in the same way we have deaths from heart disease. So this is mortality looking at women broken down by different ethnic groups. And what I want you to notice is over here is the 45 to 54-year-old woman, and it's not zero. And in fact, the red here represents Black African-American women, and so they're the highest in that age category. In fact, they are the highest in every age category. About 65, we're starting to see more increase in women in general, 75 to 84 higher, and by 85, white women and Black women are the highest categories of stroke. And this was data from 2009. So the scope of the problem is that there is a huge burden of stroke in women in the United States. Nearly half of the stroke survivors have residual deficits 6 months after the stroke. 200,000 more disabled women than men in the United States. And women are more likely to be living alone or widowed before their stroke, so they're a greater burden to their family and society. And women are more often institutionalized after stroke and have poorer recovery from stroke than men. So this is a very serious problem in our female population. So as I said, February 2014, the first ever stroke prevention guidelines for women were published by the American Heart Association and the American Stroke Association. This is approximately 10 years after the first guidelines for heart disease prevention in women were published by the AHA and the ACC, and in that time there were 2 updates to the prevention of heart disease guidelines. So I felt like this was a huge delay in timing, a huge neglect to women for stroke, and many cardiologists don't feel that we're really involved in stroke treatment, and I want to at least try to convince you today that we should be involved in tagging who's high risk for stroke, and we should be involved in the prevention of stroke in women. So it's critical to identify women at higher risk for stroke and to initiate appropriate prevention strategies, particularly early. And it's important to have guidelines that are specific to women to address the unique differences in women, such as the genetic differences in immunity, coagulation, hormonal factors, reproductive factors, and social factors. And so it's not just being a female in our bikini area like we tend to think of it in heart disease. The guidelines focus on the risk factors that are unique to women and those risk factors that are more common in women. And things like diabetes and cholesterol that are common in both are not part of the guidelines. They're part of the regular stroke prevention guidelines. So as we all know, whenever there's a guideline, it has a classification of evidence and a class of recommendation. So Class 1 recommendations are very strong. We should all do them. Class 2A are pretty good. We should consider it. 2B might have some information, but may be poor. And then a 3 is a do not do, may cause harm. And then the level of evidence, level A, has multiple populations, randomized controlled trials. B is limited data, and C may be very limited, such as case reports or expert opinion. So let's go over those stroke prevention guidelines in women. So the things that are unique to women, that are specific to women, of course, pregnancy, preeclampsia, gestational diabetes, oral contraceptive use, postmenopausal hormone use, and then changes in hormonal status. Risk factors that are more common in women than men are migraine headache with aura, atrial fibrillation, diabetes, hypertension, depression, and other psychosocial stressors. And risk factors for stroke that are common and equal in males and females are physical inactivity, advanced age, prior cardiovascular disease, obesity, poor diet, smoking and tobacco use, and metabolic syndrome. So stroke awareness is different among men and women as well. Women tend to have a longer pre-hospital delay than men. Women tend to have a higher awareness of stroke signs and symptoms and are more likely to know about thrombolytic therapy. But they are less likely to know about the 3-hour window to give these drugs and the immediate need to get to the hospital. And overall, they have a poor knowledge about cardiovascular disease and stroke. I'm always surprised in my clinic. I'll see women and they said, oh, I was having the worst chest pain ever. I thought I was having a stroke. Or they'll say, oh, I was dizzy, lightheaded. I thought I was having a heart attack. And so many times they get the symptoms confused of one for the other. So this is the mnemonic that is publicly taught and that we should all know because they're paying attention to it. It's FAST. F for face, for facial asymmetry, facial droop, arms, for the arms being different in strength or in grip, arm drift, speech, inability to say phrases, but also to say the proper word. They may use words inappropriately. And then time, the urgency to get to the hospital, to call 911, to get immediate treatment. Now, most strokes are defined as either ischemic or hemorrhagic. More than half of all the strokes are new or recurrent strokes or occurring from women annually, resulting in 55,000 more stroke events in women than in men. And 87% of those strokes are ischemic strokes, about 10% are intracerebral hemorrhage, and about 3% are subarachnoid hemorrhage. So just to review, a subarachnoid hemorrhage is when a blood vessel is ruptured and blood is leaking into the brain tissue, and it causes swelling and compression and damage to the brain tissue. Whereas ischemic stroke is a little bit more like what we deal with coronary artery disease, where you have atherosclerotic plaque. There may be plaque rupture or a clot that is formed in the heart that embolizes up here, and then the flow is stopped, and the tissue beyond that blockage is ischemic and dies from lack of blood and oxygenation. So in ischemic stroke in women, there's an age-adjusted incidence where ischemic stroke is actually lower in women compared to men, but it's more common after age 65. So before 65, you'll see it more often in men, but after 65, it's more common in women. And there are higher rates of ischemic stroke among blacks and Hispanics than among whites for both men and women. Women have a higher overall incidence of subarachnoid hemorrhage incidence than men. Again, the subarachnoid hemorrhage incidence is higher in men before age 55, but more common in women after 55. And again, intracranial hemorrhage is worse among blacks and Hispanics than whites in men and women. Cerebral aneurysm formation is also higher in women. There's a greater prevalence of aneurysm in the posterior communicating artery in women. I thought this was interesting. I hadn't learned this in medical school. There's no convincing evidence of increased risk of aneurysmal subarachnoid hemorrhage in pregnancy, during the peripartum period, or before age 50, and there's no greater risk of rupture in men or women. So women aren't more likely to rupture if they have an aneurysm. So let's talk a little bit about hypertension in women, because this is probably our best opportunity for identifying high-risk women and making a difference. So hypertension is the most common modifiable risk factor for stroke in both men and women, and it's the highest population attributable risk. And some, but not all, studies have shown that women are more likely to have hypertension than men, and women may have higher risk of first stroke with hypertension than men. So the Women's Health Initiative showed that older women, and they had a mean age of 63, that had pre-hypertension had a 93% increased risk of stroke compared to normotensive women. So this is that group of the systolic in the 130s and the diastolic in the 90s. Many times we wouldn't have even implemented treatment at this stage, and with the new hypertension guidelines set at 140/90 for treatment, these women would not be treated by current guidelines. As you all know, this is very controversial, and the hypertension guidelines are still being addressed and battled out. It's very important, though, to treat women early and have sustained treatment of hypertension if we want to prevent further strokes in women. And a recent meta-analysis of 31 large randomized controlled trials showed that treatment of hypertension in women after age 55 was associated with a 38% risk reduction in fatal and non-fatal cerebrovascular events. This is similar to what we see in statins in preventing heart attacks. So this is an important treatment. So hypertension in women of childbearing age is very important. And I think one of the reasons it's important is we're generally not seeing this population. They have to be referred to us or come to our attention. So this is the information that really needs to be followed by the OBGYNs, family practice, and internal medicine. So pregnancy hypertension increases the risk for preeclampsia, eclampsia, and stroke during a pregnancy. And as we all know, methyl dopa has been used extensively in pregnancy and appears to be safe. Alpha blockers, beta blockers, calcium channel blockers, hydralazine, and thiazide diuretics have been used in pregnancy, but they all transfer across the placenta, and so they're less desirable in using them. Beta blockers, which we do tend to use, particularly metoprolol, decreases the risk of progressing to severe hypertension, but may affect fetal growth with a smaller baby, small gestational weight. So pregnancy and hypertension are very important. Most of these do get referred to us. Stroke is not common in pregnancy, thankfully, with 34 strokes per 100,000 deliveries. But the risk for stroke is higher in pregnant than non-pregnant women, and it's the highest risk in the 3rd trimester and postpartum. Pregnancy-related hypertension is the leading cause of both hemorrhagic and ischemic stroke in pregnant and postpartum women. So it covers both types of stroke. So increased risk during pregnancy, especially the 3rd trimester, may be due to venous stasis, edema, and being hypercoagulable, which is common with pregnancy. And stroke occurs in 34 of 100,000 deliveries, but in a non-pregnant aggregate, that's only 21 in 100,000. So it is about 1.5 times the risk. So preeclampsia and pregnancy, let's talk about this a minute. So preeclampsia is a multi-system problem in a pregnant woman. It causes hemolysis, elevated liver enzymes, low platelets, disseminated intravascular coagulopathy, acute renal failure, myocardial infarction, pulmonary edema, and even may cause stroke. It is defined as increasing blood pressure with proteinuria of greater than 300 milligrams in 24-hour urine specimen. And then eclampsia, of course, is preeclampsia with seizure. Pregnancy-induced hypertension is also called gestational hypertension, and it's generally an elevation of blood pressure frequently near delivery, and it may or may not progress to preeclampsia, and it's usually resolved 12 weeks postpartum. So what are the risk factors for women who may have problems with hypertension during a pregnancy? These tend to be the women who are obese, who already have chronic hypertension, who've had a previous gestational hypertension, or a family history of preeclampsia. This is first-time pregnancies, but also women with multiple pregnancies, any woman with pre-existing vascular disease, women with collagen vascular or connective tissue disorders, advanced maternal age over 40, and of course pre-existing diabetes or renal disease. All of these women are very high risk for hypertension leading to preeclampsia or eclampsia. So severe hypertension per the JNC-7 guidelines is a systolic greater than 160 or a diastolic greater than 110. Now you all know that JNC-8 has come out since then, but these guidelines were published February 2014, so it doesn't address that, but I don't think it's changed. And the risk of stroke and eclampsia is associated with higher blood pressures than that. The blood pressure goal during a pregnancy isn't to get them back down to 120/80, but 130 to 155 systolic improves their risk, and a diastolic between 80 and 105. So women with chronic primary or secondary hypertension, previous pregnancy-related hypertension, should probably take low-dose aspirin after the 12th week of gestation until delivery. And this is fairly new information. A lot of cardiologists have not heard about this. Also, calcium supplementation may be helpful in preventing preeclampsia. If a woman has very low calcium intake in her diet, less than 1 gram per day, she should be considered, if she has less than 600 milligrams per day in her diet, she should consider taking calcium supplements over 1 gram a day throughout her pregnancy. Another class 1 recommendation is in severe hypertension in pregnancy, it should be treated with safe and effective drugs. Generally, methyl-dopa is our first line, but labetalol and nifedipine are still commonly used with minimal maternal and fetal side effects. It's a class 2 recommendation that we should consider treating more moderate levels of hypertension. It doesn't necessarily have to be severe, but you need to take into account all these factors about the women and the potential risk benefits with the fetus. And then after giving birth, women need to be followed long-term for this. They should be evaluated for chronic hypertension when their antihypertensive drug regimen should be accordingly. You cannot use an ACE or an ARB if you're breastfeeding, and most of these women will stay on methyl-dopa and a beta blocker. Postpartum preeclampsia can occur obviously after the baby's delivered. If the woman's having a lot of shortness of breath, headaches, or swelling, she needs to be seen right away. And it's a class 3 recommendation that we should not be using ACE or ARB or direct renin inhibitors or atenolol in pregnancy for hypertension control. So the treatment of hypertension postpartum. Well, probably the thing I see where we miss an opportunity for seeing these women, as many times their OBGYNs have told them, you've delivered the baby, everything's going to be fine now, your blood pressure's fine, you're good. Don't have a baby for a year. But they don't impart on them this rather unpleasant news that now you're at risk for the rest of your life for hypertension and cardiovascular disease. And so it's really important that we work with our OBGYNs to get them to refer them back to us or primary care, definitely within the first 6 months, to start a long-term evaluation of their risk. I think the most important thing is to help them get back to a normal weight postpartum, and that can be very difficult because many of these women already started out with obesity. And then they need long-term follow-up for modifiable cardiovascular risk factors such as hypertension, smoking, and lipid disorders. So this is the ASCVD risk calculator. You can do this with these women. You'll see what their risks are, and this can help you determine if long-term, when they're no longer pregnant or breastfeeding, if they need to be on a statin or other aggressive treatments. Long-term, they're also at risk for renal disease, type 2 diabetes, stroke, and increased white matter lesions is getting more and more attention also in cardiology. We're trying to prevent dementia and other cognitive decline in these women. So for a lot of these women, when I'm talking to them about changes in lifestyle, they're sort of interested in not having a heart attack, but they really don't want to have a stroke and they really don't want to have dementia. This is where they're really focused. And I think men feel the same way about that as well. So cerebral venous thrombosis, or CVT, this causes less than 1% of strokes, and it's generally a higher incidence in women. It presents primarily with a severe headache, worst headache of your life. And fortunately, it's a little lower in mortality and a little better functional outcome. So for those of you who haven't thought about this anatomy in a while, this is the superior sagittal sinus, and then these are the transverse sinuses. And as you see over here, there's a huge thrombosis of the superior sagittal sinus, then it prevents draining, and all of this causes swelling, edema, and compression in the brain. So that's the type of stroke. It is more predominant in women, and it's associated with hormone use, contraceptives, and pregnancy, and also thrombophilic length. Any type of clotting disorder, such as antithrombin 3 deficiency, protein C or S deficiency, or factor V Leiden elevation is associated with this. Women need to have a full anticoagulation workup, but generally not until after treatment, and certainly not in the acute setting of being on warfarin. Antiphospholipid syndrome, antiphospholipid antibody, factor V Leiden, all of these can be associated with this type of disorder. So let's talk a little bit about oral contraceptions, because most women in America now from 16 to 50 are taking oral contraceptives. The stroke risk is low with oral contraceptives, but it is about 1.4 to 2 times that of non-oral contraceptive users. The stroke risk is low, but it increases with age, and where I've become concerned is a lot of women from about 45 to 52, their gynecologists are actually using low-dose oral contraceptives as their initial hormone therapy for hot flashes and other menopausal symptoms. And so these women tend to be older, they may be overweight, they may already have high blood pressure or high cholesterol. And then what about some of the new oral contraceptives, a transderm patch, the vaginal ring, an IUD? We're not really sure because there haven't been studies done looking at stroke in these women, but we think it's important that these be addressed in the future. So women who are higher risk on oral contraceptives, we all know that women who have high blood pressure or women who smoke probably should not be on this type of drug. But it's also concerning in older women, women with diabetes and obesity, high cholesterol, and prothrombotic mutations or factors. So postmenopausal and menopausal hormone therapy. We know that it is not good for women. It's not beneficial. There's nothing preventive about it. Hormone therapy with conjugated equine estrogen with or without medroxyprogesterone should not be used for primary prevention or secondary prevention. And this is a very strong class 3, level A, do not do. And then what about the SERMs, the selective estrogen receptor modulators, raloxifene, tamoxifen, tibolone? They also should not be used for primary prevention of stroke and actually can increase hot flashes and some of those symptoms. So they're not really beneficial for that. So migraine headache with aura is the one associated with stroke, not just plain migraine headaches. And what is that? Well, it can be homonymous visual disturbance, unilateral paresthesias, numbness, unilateral weakness, and aphasia, or just an unclassified speech disturbance. They generally come on with the headache, but they can also not feel a headache pain. They have this neurologic impairment for a short period of time, and then it completely reverses. Frequently goes away with migraine headache medications. So migraine alone is found in about 18.5% of the population, and more commonly in women, about 4 times more common in women, but men have it too. But the prevalence of migraine with aura is a specific type associated with stroke, and it's much lower at 4.4%. And it results in a 2.5% increased risk of ischemic stroke. And the stroke risk increases if a woman has migraine with aura and she's on oral contraceptives. So this is another group you want to try to find an alternative contraception for. As you have more migraine headaches, the risk of stroke increases. So one of the thoughts is to try to decrease the episodes of migraine headaches. Some of the medications, such as Imitrex, have been linked to cardiovascular acute coronary syndrome events, and so that might not be the best one. It is associated with ischemic stroke and intracranial hemorrhage in women, especially under the age of 55. So these are the younger women having stroke, but the risk is low overall. This might be part of our future risk calculators for evaluating stroke in women, and it is linked with milder strokes and TIA, so this is somewhat positive. So let's talk a little bit about lifestyle changes. Obesity is an epidemic in this country and worldwide. By 2030, it's estimated that 86% of Americans will be overweight or obese. Right now, the data in the state of Georgia is that 2 out of 3 women, or 66% of women, are overweight or obese. So there's going to be a big increase in this in the next 15 years. There's higher stroke risk associated with increasing body mass index. And in postmenopausal women, they're more likely to get abdominal obesity, which adds to metabolic syndrome. The larger the waist circumference, the greater the chance of stroke, and also insulin resistance leading to diabetes. So metabolic syndrome affects about 1/3 of the U.S. population, and stroke events in women are greatly favored for women with metabolic syndrome, 30% in women versus only 4% in men. And as you know, it's characterized as abdominal adiposity, mild lipid disorders, hypertension, and insulin resistant. Here's a chart. So in women, it would be a waist of over 35 inches, triglycerides of 150 or higher. That's just the upper limit of normal. In women, remember, the HDL should be much higher, so any HDL below 50 in a woman is concerning. And even when I see like a 45 or 50-year-old woman and her HDL is already 52, usually at that age it's 65, 70. So I get concerned even in a younger woman when it's just in the low 50s, because once she goes through menopause, it's going to be down in the 40s, maybe even lower. Mild elevations of blood pressure, a systolic greater than 130 or a diastolic greater than 85, and mild increase in fasting glucose, anything over 100. The old criteria said 110, so note that this is 100 in this. So what can we do with lifestyle changes? Well, actually, lifestyle and healthy behaviors do help to decrease risk of stroke in women. So a healthy DASH-like diet, physical activity, moderate alcohol intake, not smoking, and keeping a healthy BMI does help. And this is the DASH diet. You all know it. It's high in fruits and vegetables, 8 to 10 servings a day. It's also high in grains, which is a little controversial, but I think what it's important to point out to our patients is that serving of grains is really small. It's like a half a cup of cereal, 1 slice of bread, a very tiny roll. They think they're having, a loaf of bread every day to get 7 to 8 servings. So you have to point out to them it's very small servings. Then it's good for low-fat dairy, seafood, a little bit of beans and nuts, olive oil, canola oil, and then limiting the sweets. And this, of course, is the dietary approaches to stop hypertension diet. So let's talk a little bit about atrial fibrillation, because it is much more common in women. It increases the risk of stroke 4 to 5-fold, and atrial fibrillation stroke is associated with higher death and disability. The stroke risk from AFib increases with age. So in a younger person, it's about 1.5% for 50 to 59-year-olds, but by the time we're up to 80, it's 25%. Non-Hispanic whites have the highest prevalence of AFib compared to blacks, Hispanic whites, Asians, or other ethnic groups. So I tend to think this is our little old lady, our white little old lady who has AFib. The overall number of AFib cases are equal for men and women, but after age 75, 65% of the AFib patients are women. So there's more women in our elderly population, more women with AFib in our elderly population. Female sex is an independent risk factor, and so that's why in the CHADS-VASC scoring, you get a point for being a female, and as you all know, a score of 2 or higher puts you on drug. So if you have congestive heart failure, hypertension, you're over 75, diabetes, these are the points for that. Stroke, TIA, thromboembolism, you get 2. If you're 65 to 74, you get 1, and female is 1. So basically, every female you see who's had AFib after 65 is someone we could be considering for anticoagulation. And study after study show that fewer women are getting put on oral anticoagulants. Of course, warfarin has been used forever, and now the new oral anticoagulants, or the NOAC drugs, are also to be considered in women. There are very few reasons you wouldn't want to use them, but they would include, obviously you can't do it for valvular heart disease or a prosthetic valve. If someone has severe renal failure, you shouldn't use it, and if they have impaired renal function, you may need to go with a lower dose. And then the lower weight, the tiny little old lady is more at risk for bleeding complications and, of course, advanced liver disease. But as cardiologists, this is where we really have the opportunity to change the stroke risk in women. And too often we'll see a little old lady and we'll say, oh, she's going to fall, she can't take her meds, she won't be able to do this, and we dismiss the risk. But we really need to be strongly considering putting these women on oral anticoagulants. So let's talk about carotid endarterectomy and carotid surgery. So carotid stenosis also has gender differences. Women tend to have smaller caliber internal carotid arteries. Women tend to have shorter stenotic segments, and carotid endarterectomy is less performed in women, 36.4% in women compared to 53.8% in men. This is so bad that it is in fact a risk factor. To be a female means you are more likely to not get carotid endarterectomy. So as we all know, this is atherosclerotic plaque in the internal carotid artery. There's thrombus there. They basically surgically remove the plaque. And it never looks this good. I think our vascular surgeons wish it did, but they do improve the lumen and improve the blood flow. So let's go through some of the indications for carotid. And again, it's up to the vascular surgeon to do this, but if we're doing the preoperative clearance or it's our patient, I think we should be their advocate, and we should really be encouraging that they get revascularized when it's appropriate. So women with asymptomatic carotid stenosis obviously should be screened for other modifiable treatment, treated with lipids, blood pressure, whatever is appropriate with lifestyle and medical therapies. Women who are undergoing carotid endarterectomy should be on aspirin. All of the large trials have showed good outcomes and efficacy when aspirin is used. For a woman who's had a recent TIA or ischemic stroke, and ipsilateral moderate blockage in the 50 to 69% stenosis, carotid endarterectomy is recommended depending on specific factors, particularly if her overall risk of surgery is low. For women with a recent TIA or ischemic stroke within the past 6 months and ipsilateral severe carotid artery stenosis, it is also recommended if she's a reasonable candidate. And if she's very high risk and can't take aspirin, we should be thinking about clopidogrel in these women. So let's shift to aspirin for primary prevention of stroke. So aspirin therapy, particularly in women after 65, is beneficial for reducing the risk of stroke. I think it's important to point out that their blood pressure needs to be well controlled. And if you have a woman whose blood pressure is 180, 190, 200, you might want to stop that aspirin temporarily, get her blood pressure under control, and then have her resume her aspirin. Also, you want to be balancing the risk of a GI bleed or other type of bleed. So the risk factors that are unique to women for stroke obviously are related to pregnancy if she's had preeclampsia, eclampsia, or gestational hypertension. Hormone exposure, women on oral contraceptives, again, be particularly aware of women in their late 40s, early 50s who may still be on this low-dose oral contraceptive as part of her hormone replacement therapy. And then the postmenopausal woman on hormone therapy. And the changes in hormonal status throughout a woman's life, when she changes from menarche to menopause, and then if she's had an oophorectomy, all of these affect her risk for stroke. And then, again, try to be much more aggressive with atrial fibrillation in the elderly, putting these women on proper anticoagulation therapy. So some of our future goals, because there's still a huge unmet need here, is to improve the accuracy of stroke risk assessment, particularly in the office. Hopefully these guidelines will get us started thinking about that. We also need to assess stroke risk when a woman's had preeclampsia or other pregnancy-related complications, and getting her plugged in with the primary care or the cardiologist early is of vital importance. We need prospective data on these women long term, particularly the ones who've had pregnancy complications. And we need better stroke prediction models for women that take these into account. We need epidemiologic studies on stroke subtypes, not just ischemic, but hemorrhagic and CVT. We need to look at it by age and sex differences. And we need to increase awareness among women in the population that obesity, hypertension, and diabetes, even in our young women, is associated with stroke. And again, the risk with pregnancy. We need to be working with the OBGYNs to have them send them to us when it's appropriate. We need better preventive strategies, and we need to recognize the sex-specific factors and include these in our risk assessment. And there's not a drop-down box anywhere in our EMR to include this, and so it's really important to put in there gestational diabetes, gestational hypertension, preeclampsia. I have recently written a review article called Burden of Stroke in Women. It's currently online and is soon to be published in Trends in Cardiovascular Medicine, and it gives a much more extensive review of this in detail. So if you are interested in this, I would encourage you to read it. Let me tell you a little bit about the Emory Women's Heart Center and what we're trying to do to prevent stroke in women. So this is our team. We have a great team, and Lila Butt's here today. Thank you. Our goal is to screen and educate women in Atlanta on their cardiovascular disease risk. So that includes stroke as well as heart disease. We also do a lot of community programs to educate women, but we also work with healthcare providers, and we do a medical education event every summer that many of you attended, some of you have spoken at, and we try to address these to healthcare providers for women. A specific program that we have going on right now is called Screen 10,000 African American Hypertensive Women in Atlanta. And we actually had an event this Saturday at Tri-Cities High School off Sylvan Road. We screened about 40 women. And it was very important. So many of these women had blood pressures 160, 170, 180. They're not plugged in with healthcare providers. And we had an opportunity to talk to them about these risks and to try to lower stroke here in Atlanta. We're going out to churches, high schools, community groups, anybody who'll invite us actually, and trying to do these screenings. And then the most important thing we're doing is trying to provide hypertension follow-up and treatment. So Mercy's working with us, Mercy Care, Grady, and then all the Emory Women's Heart Centers. We have 6 locations are working on this. So again, we think it's really important to try to lower the risk of stroke in women. And we do think that this is important for cardiologists, preventive cardiologists, to be addressing this. We do have a small grant, and we are working on education with this women. One thing that I'm particularly passionate about is social media and Twitter. And so we have a Twitter account to try to reach these women. It's called 10,000 Women. And 90% of the women we saw this weekend had smartphones and had Twitter. Some of them are on Facebook, some of them are on Twitter. We signed them up right there. But the point is to send out messages continuously throughout the week about sodium, exercise, did you see your provider? It also gives them a way to follow up with us if they want to. So we're very excited about this project. If any of you want to volunteer for it, it's on the Emory website, 10,000 Women Volunteers. We're going to be doing it for 5 years. So if any of you is interested, please let me know. And I can take questions now.
Thanks, Gina. Sorry about the IT issues. It's all my fault. I must not be reading things wrong. I'll start with one question. And so in pregnancy, the guidelines for treatment goals are higher than one would typically expect for hypertension, and then you allow a little more hypertension. And that's a little perplexing given that the normal physiology of pregnancy is for lower blood pressure because of lower peripheral resistance. Is that just sort of a safety margin, or is there some data that actually drives that? Is that an expert opinion sort of thing that sets that goal?
I believe it's more of an expert opinion. So some of these women, their blood pressure is so high, you have them on max labetalol, max methyldopa. You may have them on other things, and so you feel like if you just get it down to a safer zone, you don't want to be adding more medications. But I've also seen women that you add a little nifedipine and they bottom out. So I don't think every woman with hypertension during pregnancy is having the exact same pathophysiology of what's going on. So it may be that there's a more resistant type, and then obviously there's an easier to treat type. A lot of this data has been retrospective analysis and not a lot of forward treatment. And again, we have to work with the OBGYN seeing these people to follow the hypertension and track it. What I do is I see these women very, very frequently because I've seen them be on a lot of medicine and then just suddenly it'll drop. They get more vasodilatation or they quit eating salt or something kicks in. They actually take their medicines on time. And then that can be scary too because you don't want it to drop too low when they've been used to perfusing at that high level.
Any questions here? You have to repeat them because mics aren't working.
Doug has a question.
I just make a comment. An excellent talk, and I wonder if we're not missing an opportunity by not recording talks like this and having them available in your waiting room. That is, if somebody comes in and sits down and they're going to be waiting 30 minutes or something for a visit, that they could tune in on something like this. So I think you had a lot of valuable information that would be nice to get into the public's hands. And maybe you're doing it in other ways. But
we're not doing that. That sounds like a great opportunity, and I believe you're in charge of the Emory Clinic. You're probably the guy. You're probably just the guy to make that happen.
well,
So we'd be glad to do that.
You're not the first person to point this out to them. So,
We tried a few years ago, and they told us there wasn't a way to, which is bizarre, because I think in Grady, right? Don't you guys, Rebecca, didn't you?
We had DVDs, like professional medical DVDs, that I believe are still playing.
Yeah, they go into the winter education room, more about their stroke or.
But they also play in the lobby, because now I heard it was like policy that we can only show HGTV.
Well, there is a policy that you have, your things are limited because you can get a lot of things on television. And so they did limit that. But one concept that I have thrown this idea out is people say that we should not have waiting rooms anymore. I mean, and rather than having waiting rooms, having an educational forum or something that you could go in and sit down and watch something, and maybe you could have it set up where different people could be seeing different educational things. You wouldn't force them to, but you'd have an opportunity to do it.
Better than Judge Judy and.
Exactly, yeah.
Whatever else is on.
We have the CardioSmart education series in our waiting room at East Cobb, and it's just all this general information about blood pressure and cholesterol that's going all the time, but I don't think they even have anything about pregnancy and hypertension. That's an opportunity. Okay, I don't have that. I'm sorry. But here's what's interesting, because I do take this really detailed pregnancy history with my patients, and they'll be like, did you have any blood pressure problems? Even at the end, did you have any preeclampsia? Did you have any babies over 9 pounds? All this, and they'll kind of be like, Dr. Lundberg, I thought you were my heart doctor. Why are we talking about all this? And you can tell that they've never been asked this. So I think it's really important for us to ask that, or put it on your intake sheet, or have the nurse who pre-screens your patient before you come in ask about these things. Because when we're looking for, why did this lady have a heart attack? Why did we have a stroke? Usually in retrospect, we start finding out, wow, she had migraine with Aura, and she had preeclampsia with 2 of her kids, and then it sort of adds up. But we need to find it on the preventive side so we can say, hey, we want to watch you a little more closely. I'm not going to see you back in a year. I'm going to see you back in 6 months because you're a little more high risk than we thought. So I think it can be clinically very important to take that history.
I wondered if you even had that, if you took a history and had check boxes, and if you check it one way, one thing, it has in blue or red or something, so you need to discuss this with your cardiologist or something.
It is on our, that HD that they fill out.
Yeah, but my question is going a step further, and if you feel like you check in one area, then you're right then told on a piece of paper, whatever you pamphlet, please ask your physician about it.
Mm-hmm. I'd be glad to work with you on that.
Okay.
The whole team would. Thank you very much.
You're the change, man.
Glad to help. Anyone else?
Any other questions? Okay. Well, thanks so much.
Thank you so
Gina.
much.
Appreciate it.
The preceding program is copyrighted by Emory University.